Great, thanks. You know, I guess I kind of lost count. If it was really 37 previous presentations as visiting professor, you'd think I'd be a little better at it. But I guess, you know, practice makes perfect, as they say. So thank you very much, Peter, for inviting me, and Dr. Marin as well. I was really entertained by the Grand Rounds experience this morning. I think we should try to do something similar back at home base. So it is a little warmer in California right now, but you know, got to take the good with the bad. So I have some disclosures: consulting, grant support, educational support, material transfer agreements, and research contracts related to this topic. So just briefly, this is our group. We work at 4 different medical centers. We have a pretty diverse case mix. We do a lot of aortic aneurysm work, both dissections and aneurysms, as well as kind of a potpourri of vascular management. An interesting facet of our practice is we do a lot of athletic vascular injury, branch artery aneurysms of the axillary arteries, iliac endofibrosis, and competitive cyclists. We see a number of professional and Olympic class athletes for those problems. In complex venous reconstruction, we have a robust research portfolio with funding from the NIH as well as California Institute of Regenerative Medicine and other nonprofit institutions. This is our current resident cohort, both integrated residents and our fellow group. And our practice has really regionalized in the last 10 years. We have affiliated clinics throughout the San Francisco Bay Area, and our practice volumes have grown tremendously. Just in the last year, our RVUs are up 27%. In a relatively mature practice, that's a remarkable increase year on year. So the topic of today's presentation is abdominal aortic aneurysm disease. Most of you know it's a common, a lethal problem, although interestingly the prevalence, or I guess incidence, of aortic aneurysm disease seems to be decreasing in the United States pretty dramatically over the last 20 years, but it remains common, lethal. The pathobiology is complex. We'll talk about that during the presentation today. And it is kind of a unique mix of environmental and genetic risk that kind of makes it challenging to understand how to actually manage the disease in its earlier stages. If you want to just look at a summary of the pathophysiology of abdominal aortic aneurysm disease, this is from a textbook chapter that we wrote a few years ago in the setting of specific genetic predispositions, some of which we'll talk about today. More and more is being understood about the particular genetic polymorphisms that put patients at risk for aortic aneurysm disease with exposure to these known risk factors for aneurysm disease. A process starts sometime in middle age with immune inflammatory response, something like an autoimmune problem. Most people feel today it's a T-cell mediated process, which then is amplified by certain biomechanical factors present in the region of the infrarenal aorta that triggers proteolytic mechanisms, which then break down elastin, and elastin degradation products are chemotactic for macrophages, and this cycle starts of destruction and proteolysis, which eventually causes the abdominal aorta to weaken and in worst case scenario, rupture. Interestingly, there's really an interesting kind of uptick in scientific interest in abdominal aortic aneurysm in the United States. If you just look at the number of papers published, this is from PubMed. Whenever if you do a Medline search on aortic aneurysm disease, it shows you the number of papers published per year, and you'll see that for decades there's just a minimal amount of publication interest in aortic aneurysm disease. And starting about the mid-90s, there's an asymptotic increase in the number of these publications, and there's a number of reasons for this. Part of it's the biology was catching up to our clinical understanding of the disease. Part of it was advanced clinical progress, but part of it is that there's a certain number of advocates in positions of authority who could actually, drive this agenda. And one of them, this Momtaz Wassef, who was a program officer at the NIH. And every time there was an RFA that had anything to do with vascular remodeling or inflammation or atherosclerosis, Momtaz always made a point of inserting a paragraph in the RFA to make an aneurysm proposal responsive to that RFA. This started, the first one was in 1999, and there were several subsequent to that. And it really sometimes takes people like that to really drive the agenda and improve care for our patients who are committed to really making sure that these problems get full attention. And of course, my predecessor and mentor, Dr. Zarins, had a lifelong interest in aortic aneurysm disease, and in conjunction with Dr. Seymour Glagoff at the University of Chicago, had done a lot of pioneering work in the pathophysiology of aortic aneurysm disease, which subsequently led to the commercialization and development of the first two FDA-approved aortic endografts here in the United States. There's actually quite a bit of information understood now about who actually develops an abdominal aortic aneurysm. The Society of Vascular Surgery, partnering with the Lifeline Foundation, which is a for-profit organization actually that does screening, ultrasound screening tests for patients. So Lifeline database has actually more than 4 million exams that they've performed in the United States, and each of these patients who signs up for Lifeline screening fills out a 100-question questionnaire about their demographics and background. And a few years ago, the Society of Vascular Surgery, Craig Kent was the first author on this paper, looked at associations identified through the Lifeline screening database. And you can see that if you look at the odds ratios for risk for aortic aneurysm disease, it's over 3 million people that actually underwent screening, and of those people who actually were found to have aortic aneurysms, you can see there's a dose-response effect to increasing age in terms of an increasing odds ratio of having aortic aneurysm disease. Almost any ethnicity other than Caucasian is protective against having aortic aneurysm disease. There's an exquisitely close dose response to both duration and intensity of cigarette smoking. And then there's some other interesting facts. For example, having diabetes is a significant protective effect against having aortic aneurysm disease, which distinguishes it from other atherosclerotic endpoints. Smoking cessation appears to be remarkably protective, particularly if it's more than 10 years before the screening test. And even obesity and exercise, just exercising at least one time a week seems to have some protection against aortic aneurysm disease. So actually, as of today, we're pretty clear about who does get aneurysm disease and who doesn't, at least based on environmental exposures and behavioral statistics. So then if you extrapolate from that list that we just looked at, the hierarchy of known risk factors for aortic aneurysm disease in order is age, sex, tobacco exposure, familial risk, ethnicity, waist circumference, and height, in terms of the relative weight of each of those things in developing aortic aneurysm disease. And again, the issue between cigarettes and aneurysm deaths as experienced in this last century is really remarkable and worth just a little bit more consideration. So this is an editorial that Frank Lederle wrote in Circulation in 2011. He was the principal investigator on the U.S. Department of Veterans Affairs Aneurysm Development and Management Trial, ADAM trial. And if you look at per capita cigarette consumption in the United States beginning in the early decades of the 20th century, it's a remarkable increase, followed almost 20 years later with a parallel increase in mortality from ruptured abdominal aortic aneurysm. And as you can see, that cigarette smoking peaked in popularity in the late 60s and 70s and has declined substantially since then on a per capita basis. The mortality from aortic aneurysm disease has also declined dramatically during that same time. Although interestingly, these slopes are a little bit different, not exactly parallel, suggesting that other influences may change aneurysm mortality. Part of it may be improvement in surgical technique and the introduction of endografting, but there clearly is a very close relationship between cigarette consumption and aneurysm disease. This decline in aneurysm mortality, however, is not uniform across the world. This is a paper just published this year in Circulation showing that the UK and the United States actually have relatively low and declining aneurysm mortality, but other societies in the country, in the world, have a different experience, and this, of course, probably relates to the prevalence of smoking worldwide and differences between men and women. So it's not true necessarily that aneurysm disease is going away. It's just shifting as social habits change in terms of particularly cigarette consumption. So then if we move down this hierarchical list, as I mentioned, age is, of course, very significantly responsible for aneurysm risk. Men are 4 to 5 times more likely to develop aneurysms than women, and Gib Upchurch, particularly at the University of Michigan, now Virginia, has been particularly interested in sex differences in terms of aneurysm risk. If we move then down to familial risk, there's an interesting paper published in the journal in January it's from Erasmus Medical Center in Rotterdam, looking at their aneurysm experience over 10 years. And each of these patients, they determined whether there was a familial relationship of aneurysms. Was there a first-degree relative of the patient they were operating on who actually had an aneurysm? They called that a familial aneurysm. They compared that to spontaneous aneurysms, meaning that they didn't have a first-degree relative. And then they simply looked at common carotid artery intimal medial thickness on ultrasound between the familial aneurysms and the spontaneous aneurysms. And they recognized that there were significant differences in this intimal medial thickness, which is kind of a derivative assessment of atherosclerotic exposure. And what they found was that the spontaneous aneurysms had higher incidence of smoking and hypertension, and the familial aneurysms tend to be younger and didn't have the smoking hypertension. And so, in essence, the suggestion is that there's really a bimodal distribution of aneurysm risk. In patients who really have a familial risk, a much lower exposure to risk factors probably drives aneurysm progression compared to patients that don't have a familial risk. And there is a number of, there's kind of a consensus understanding now that aneurysm prevalence in the US has kind of shifted to an older demographic. Patients who might have developed aneurysms at an earlier age when smoking was more prevalent are now developing them at a later age because smoking is less prevalent. Sorry, wow. Maybe I should try to just do with this rather than the wheel. Apologize for that. And so what exactly is the familial risk, the genetic risk? There's been a number of gene-wide association studies performed around the world. There have been a total of about 30 loci identified that appear to relate to coronary heart disease. And of these, by far the most robust association is on chromosome 9, position P21. This accounts for, this single polymorphisms at this particular location account for about 20% of all genetic variation that relates to risk for coronary heart disease. On this Manhattan plot, for example, appropriate here in New York, you can see there's significantly more hits for 9p21 than any other known polymorphism for coronary disease. So one of our faculty, Nick Leeper, works in our group, has identified that absence of CDKN2B, cyclin related to cell cycling, cell survival, and apoptosis, upregulates P53, which causes smooth muscle cell apoptosis. And they've introduced this new concept that aneurysm pathophysiology may not simply be an inflammatory issue, but may be related to the viability of aortic smooth muscle cells, and that may in fact be a principal cause of aneurysm pathogenesis, particularly in a familial risk association. We've also identified epigenetic regulation related to aortic aneurysm disease. Our research group in this last couple of years has published a couple papers on microRNA and its relationship with aneurysm progression. miR29B is related to the production of components of collagen, both collagen components and cross-linking. It's, if you modulate expression of miR29B with antagomeres or gain or loss of function experiments, appears to modulate experimental aneurysm progression. It's expressed in human aneurysms, and more recently a miR21, which is related to the P10-AKT pathway. Just as an interesting aside, about 70% of patients with prostate cancer have a somatic mutation of P10, which basically is a tumor suppressor gene. When absent, seems to accelerate the progression of prostate cancer. And in the setting of abdominal aortic aneurysms, if the absent this microRNA 21, there appears to be a rapid acceleration of aneurysm progression. It's present in humans and may in fact also represent a novel biomarker. So both genetic and epigenetic regulation of aneurysm risk appears to be significant predictor of disease likelihood in a growing number of patients, and we have a greater understanding of that problem now as well. If we look at waist circumference, so it's interesting about the obesity component, and this isn't about surgical risk or signing a consent form saying you're going to die, but actually it's not simply an issue of BMI, it's the question of where the obesity is. It's the waist to hip ratio is much more sensitive and reproducible marker of aneurysm risk than just BMI overall. John Gollage in Australia identified this first. It has to probably do with his adipokines, these hormones that fat cells produce, which can drive inflammation. And it turns out that male pattern obesity, or particularly waist circumference, is a particularly significant risk factor for aneurysm disease. So this was a study that was done in Sweden where they looked over 10 years. You know, in the Scandinavian countries, they collect data on everything, on everybody. And over 10 years in Sweden, patients who had aortic aneurysm repair, they looked at simply what their waist circumference was in terms of the likelihood of requiring an aneurysm in a couple of large databases that they were following. And the risk for aneurysm, aortic aneurysm disease requiring surgical repair goes up significantly as you have an increasing waist circumference up to about 101 centimeters, and beyond that point, additional waist circumference doesn't seem to have much of an impact. So obesity is important, but it's most important of where it is exactly and how that influences risk. And then, of course, there's this other interesting observation about height. In general, if you look at across the 20th century, the population has grown taller around the world. It's like almost on average about 5 centimeters taller. And if you look at hazard ratio per 1 standard deviation, which is about 6.5 centimeters higher baseline height, you see that taller people are in general protected from almost all manifestations of cardiovascular disease, heart attacks, strokes, almost everything, with the exception of ruptured aortic aneurysm. And of course, there may be some influence of syndromic aortic conditions like Marfan syndrome in this assessment, but it's interesting that height seems to be a unique risk factor for aortic aneurysm disease compared to all other cardiovascular event risks. So if we move then from just what's the risk of developing an aortic aneurysm and the likely pathophysiology of the problem to a more clinically relevant question, which aortic aneurysms progress, that's also an area of intense research right now, and there's some reason to believe that they'll be able to identify biomarkers potentially to help us with this assessment, because there are plenty of patients that have aneurysms that will never need surgery, and some of those people are going to get complications from operative repair, and it'd be helpful if we could stratify risk of progression more precisely. So there's a screening study in the UK, Chidester screening study, which has been going on for over 25 years. It's a district-wide screening program, and so from this database, they've been able to determine what happens to these patients who've had these aneurysms identified as screening. And you can see that, and this is typical for most screening data, if you screen an at-risk population for aortic aneurysm disease, this is aortic diameter versus the prevalence at these various diameters. Most aneurysms identified as screening are small. If we define an aneurysm as 30 millimeter aorta or greater, the majority of these aneurysms identified as screening are small, and you see drops off pretty precipitously as it gets larger. This is similar to the USADAM data, where about 4% of patients screened through the VA system had aortic aneurysm disease, but 90% of those were less than 4 centimeters in diameter. But if you then extrapolate to what happens 5 years after these patients have an aneurysm identified at screening, or 10 years after these patients have an aneurysm identified at screening, you see that some aneurysms never progress. They stay in this low range. Some, on the other hand, progress significantly, and this is true at both 5 and 10 years. So the question is, what separates these aneurysms from these aneurysms? Is it just cigarette smoking, or is it genetic predisposition, or what exactly differentiates the aneurysms that will or will not progress? The only real two risk factors that appear reproducibly to have an influence on aneurysm progression are cigarette smoking and diabetes. This is from the group that put together the UK SAT small aneurysm trial, Janet Paul and her collaborators at Imperial College in the UK. And so if you look at these pooled estimates of studies which have looked at aneurysm progression with cigarette smoking, we can see that the vast majority of these show evidence of progression for active smokers versus non-smokers, and the average growth rate is nearly about 0.5 millimeter a year faster in active smokers than non-smokers. And if you look at these pooled studies of patients with diabetes, we see that diabetics actually, not only are they less likely to get aortic aneurysms, but their aneurysms actually grow more slowly during surveillance. And these are really the only two risk factors or environmental exposure conditions currently that have a known influence on aneurysm progression. This diabetes is kind of a special case because if you think about the fact that the operative risk is higher, odds of mortality for death with aneurysm repair is like 1.26 for diabetics versus non-diabetics, and a relatively shorter life expectancy that diabetics have versus non-diabetics, plus the fact their aneurysms are likely to grow more slowly, it kind of begs the question of whether diabetics with aneurysms should be considered differently from non-diabetics in terms of whether they should have operation or when they should have an operation. In terms of the potential mechanisms related to nicotine and its influence on aneurysm disease, there was a paper published in Nature Medicine 2 years ago which for the first time appears to identify a specific mechanism related to nicotine and aneurysm progression. It has to do with the upregulation of this adenosine monophosphate kinase alpha-1 gene. Appears to be upregulated by nicotine, and so if you look, for example, in mouse models, if you expose a hyperlipidemic mouse to nicotine, they will develop aneurysms in the abdominal aorta, but if you knock that particular gene out, they don't. The mechanism appears to be related to AP2 alpha expression of vascular smooth muscle cells and then an upregulation of MMP2 expression. This upregulation of this gene is present in abdominal aortic aneurysm tissue from humans, and cigarette serum levels are also increased in cigarette smokers. So there may be other mechanisms, but this is really the first time a linkage has been made between a specific gene and nicotine exposure and a potential mechanism related to cigarette smoking. We've worked a little bit on the mechanisms of diabetes suppression, and this was my lab group in 2009. This is Naoki Miyama, Yuki Miyama, who was the primary driver of these experiments, along with Monica Dua, looking at potential influence of hyperglycemia on experimental aneurysm progression, the fact that we could restore the aneurysm phenotype when glucose levels were controlled with insulin. Another interest that we've had in the last many years, and I'll just go in a little more detail about this, is why there's regional variation in where aneurysms occur in the aorta. So most of you who are vascular surgeons realize that infrarenal abdominal aortic aneurysm is about 5 times more common than thoracic aortic aneurysm. And why is it? You know, in research, actually, there's a lot of opportunity around recognizing certain situations where things aren't what they appear to be. So, for example, why is diabetes protective against aortic aneurysm disease when it seems to be, promote all other forms of coronary vascular disease? Why is gender differences appear to be protective, and why are women less likely to get aortic aneurysms than men? And similarly, why do aneurysms occur so much more frequently in the infrarenal aorta? Well, I mean, there's multiple possible explanations. One is smooth muscle cells come from a different germ line, a different cell line during development from the infrarenal aorta than they do the thoracic aorta. And that also explains possibly why aneurysms occur in the common and internal iliac arteries, but not the external iliac arteries, because the smooth muscle cells are derived from a different mesoderm, ectoderm area. But another explanation might be that the hemodynamic conditions, the conditions of blood flow, vary significantly in these two portions of the aorta, and that may also be part of the difference. And one example of that is if you do an open magnet study with exercise, you can see that in the infrarenal aorta, during a majority of the cardiac cycle, where this blue slice is right here, there's a retrograde or oscillatory flow in the infrarenal aorta, whereas in the suprarenal aorta at rest, there's antegrade flow throughout the cardiac cycle. And there's multiple experiments. Michael Gimbroni demonstrated this first at Harvard, that this oscillatory and retrograde flow causes expression of pro-apoptotic, pro-inflammatory genes in vascular smooth muscles, and this continuous antegrade flow hemodynamic conditions seem to be protective against many of these changes. in really modest levels of exercise can completely obliterate these pro-inflammatory conditions in the inferior aorta, suggesting that lower extremity activity, the amount that you walk every day, might be protective and to a certain extent for abdominal aortic aneurysm disease. So we considered this question of does flow or wall motion influence the regional risk of aortic aneurysm disease in the inferior aorta. Clinical relevance of this is first this observation by Volmar and German World War II veterans 45 years after the war that above-the-knee amputees were 5 times more likely to have abdominal aortic aneurysms than patients who had not had a amputation when all other risk factors were controlled, including cigarette smoking, and that the shape of the aneurysm was reproducibly related to which of the 2 legs had been amputated. This paper was published in 1989, and when I was a resident I was kind of interested in this. And we've subsequently gone on to show a similar relationship in spinal cord injury patients, that spinal cord injury patients are more likely to develop aortic aneurysm disease when all of the risk factors are controlled. And even in spinal cord injury patients who don't have an aneurysm, there's this pre-aneurysm phenotype of inferior aortic enlargement, which appears to be present frequently in this patient cohort, suggesting that there's something about this reduced flow at the aortic bifurcation in patients who are non-ambulatory that might increase aneurysm risk. So we've reproduced this in experimental models where an aneurysm initiated, and we can increase flow either by creation of an aortic cave of fistula or exercising the animals, or we can reduce flow either by unilateral iliac ligation or sedentary activity, and the high flow aneurysms get smaller and the low flow aneurysms get bigger. And this is how we create these models. Porcine pancreatic elastase is infused in the inferior aorta, unilateral iliac ligation or aortocaval fistula placement, and these are high, normal, and low flow aneurysms in terms of rate of enlargement of these aneurysms. And to make sure that our models are physiologically relevant for human disease, we developed a scaling exponent across mice, rats, dogs, and humans, demonstrating that there was a linear relationship on a log scale in wall shear stress across all these species to try to make sure that our changes were relevant to the human condition. And then we moved on to actually exercising the mice. So it turns out if you put a mouse in a cage and have a wheel in there, the mouse will run up to 5 kilometers a day when a wheel is present versus not. And so by creating aneurysm in these mice and giving them the opportunity to exercise, we can see that exercising mice aneurysms are smaller at several time points after the development of an aneurysm than non-exercising mice. And mechanisms related to this, we've published a number of things related to this. There's high flow conditions appear to reduce oxidative stress. They promote smooth muscle cell proliferation and cellularity, and more recent data suggests that some of the microRNA mediator expression might be related to this. Reduces macrophage infiltration and chemotaxis into the aneurysm, and also increases circulating vascular progenitor cells, CD34 positive cells, which very recently, just this last month, there's a paper in one of the American Heart Journals suggesting that this might be a reasonable biomarker for aneurysm disease progression. We've looked at mechanisms of flow modulation. So it turns out in one of these models, a hyperlipidemic mouse model, aneurysms always occur in the same location, just above the right renal artery, and always seem to bulge out in the same direction. So we basically figured out that the direction in which the aneurysm, the aorta, seems to move with each heartbeat, the vector of that direction can predict where the aneurysm will actually occur. And we can use this fluorophore, this MMP sense, to look at the amount of proteolysis that's present in that part of the aneurysm, and we can predict which direction the aneurysm will grow by which direction it's moving, which direction the aorta is moving before the aneurysm is initiated. Now there's also potentially systemic benefits of exercise on inflammation. Very short periods of exercise, even just 2 weeks, significantly reduce your circulating CRP or IL-6 levels, which are markers of inflammation. And even in patients who self-report the amount of exercise that they do, CRP levels actually correlate quite well with self-reported activity levels for light, moderate, or heavy exercise. So it might be a local effect of blood flow, but it might be a systemic benefit of exercise. that has some potential benefit on aortic aneurysm disease. So we then moved to trying to model some of these influences that blood flow has on the infrarenal aorta. This was with collaborator Charlie Taylor, who was on the engineering faculty at Stanford before he left to actually start his own company. So we start with image-based geographic model construction methods. We then incorporate realistic boundary conditions for all the outlet vessels of the abdominal aorta, and then use numerical methods to compute pressure, velocity, shear stress, and wall motion. And we can use magnetic resonance to quantify flow in the infrarenal aorta throughout the cardiac cycle. And we then build a finite element mesh with millions of nodes to look at shear stress at multiple points throughout the aorta continuously. As I mentioned, we integrate these boundary conditions, which are basically resistance, like electrical circuit resistance for each of the vessels that provide outflow for the abdominal aorta. And then we incorporate rest and exercise conditions. And the reason this is important is because there's some evidence that low wall shear stress, again, as is present in this sedentary situation, can actually promote aneurysm progression. So this was a paper published a few years ago at UCSF. This is actually an intracranial aneurysm, but if you look at wall shear stress is calculated for these intracranial aneurysms, and then you look a few years later at changes in aneurysm diameter, the areas of lowest wall shear stress actually were the areas that grew the most rapidly in the same intracranial aneurysm over time, suggesting that these differences are physiologically significant. So based then upon our interpretation of this idea that blood flow conditions may influence aneurysm risk, we began a clinical trial. The AAA abdominal aortic aneurysm STOP trial, simple treatment or progression. The idea was to provide exercise training to patients with small aortic aneurysm disease and then see if that influenced the progression of disease. This was a SCOR program project grant funded through Heart, Lung, and Blood. And we had a proteomics core as well as a bioengineering computational assessment core. And the idea was, over time, to see if the exercise would prevent aneurysm progression, but to study both exercising and non-exercising patients to see if we could pick up biomarkers of response to the treatment. Sorry. Let's go back just a little bit. So we eventually screened 3,600 patients, of whom 1,200 were contacted, 789 were asked to participate. Eventually, wound up with 140 patients randomized to exercise or usual activity. At least 125 completed 6 months this trial, testing at multiple endpoints. Primary trial endpoint was maximal sagittal aortic diameter by ultrasound, which in retrospect was a weakness of the study, and we learned a lot in the context of this. Secondary endpoints were safety, exercise response, and maximal exercise expenditure. The average participant participated in this trial for almost 2 years with 3 days a week supervised exercise training. More than 81% completed more than 1 year. There were no training adverse events. Significantly greater number of patients in the usual activity group ultimately underwent aneurysm repair, although there were no ruptures or any problems related to that. Patients were enrolled anywhere with aortic aneurysm between 30 and 49 millimeters in diameter. And energy expenditure the study was actually quite successful in doubling the average amount of kcals expended per week in participants of the trial. And you can see that, as noted previously, exercise pretty much completely obliterates this at-risk hemodynamic pattern present in the infrarenal aorta at rest. It makes the infrarenal aorta blood flow conditions look quite similar to the supraceliac aortic blood flow conditions, which is our hypothesis, one reason why patients develop aneurysms in the infrarenal aorta. And you can see that if we look at velocity in the infrarenal aorta, modest amounts of exercise almost completely obliterate this at-risk low flow condition present in the infrarenal aorta at rest. So as I mentioned, maximal exercise time increased significantly for these patients, showing good training effect, although it kind of plateaued out after about 12 months. and using a mixed effects model, aneurysm progression did seem to be lower in patients that were exercising compared to non-exercising, but for a variety of reasons, standard deviations, reproducibility, that kind of thing, this difference turned out not to be statistically significant. And if we had made our estimated sample size from our pre-study power calculations, we might have been able to show a difference, but as it stands, all we can say is it seemed to be trending in the right direction and patients were not harmed by exercise. The study has developed a number of derivative outshoots. One, for example, is a potential biomarker panel looking at a number of biomarkers used in conjunction to look at predicting progression versus non-progression or response to exercise. And we also have developed a significant number of techniques to look at non-serologic markers of aneurysm progression using, for example, molecular imaging techniques, FDG PET, iron-based macrophage contrast agents for MR, the fluorophore Cy55 tagged to VEGF looking for angiogenesis within the wall, or these ferritin nanocages which look at integrin expression. And we're trialing several of these things in additional clinical studies. One of the residents working on this project with Maureen Tedesco won Hilary Sanfie Outstanding Resident Award for her work in this area from the Association of Women Surgeons in 2011. There are a number of medical trials which have been attempted to manage early aortic aneurysm disease. This is pre-surgical aneurysm disease. Anti-impulse hypertension studies like beta blockers have never been shown to work. Anti-protease trial, the doxycycline trial is actually ongoing right now. It's called the INTACT trial. Are you participating in that here, Peter, the doxy trial? No? We're participating in that trial. There's some anti-inflammation trials. We're the U.S. site for the TEDdy trial, which is an ARB trial, angiotensin receptor blocker trial. There's been some interest in statins in this area. For example, the statins in the Dutch doxycycline trial, patients who are on statins versus non-statins seem to have a more favorable activated to non-activated macrophage ratio. Mast cell inhibitor trial is ongoing in the UK or in the EU, but seems to probably not be effective. And most recently, we're starting this mesenchymal stromal cell trial through the Cardiovascular Cell Therapy Research Network. The idea being that infusion of bone marrow-derived mesenchymal stromal cells depress T cell activation, and there's both clinical and experimental data. Clinical data from kidney transplant patients, for example, it can reduce rejection with infusion of mesenchymal stromal cells, and so we're starting this trial now through this NHLBI-funded CCTRN trial network. So in summary, abdominal aortic aneurysm disease is really a changing demographic. Its prevalence is decreasing, or incidence is decreasing in the United States, not necessarily around the world, but it's still a common and lethal disease. It would be useful for a variety of patient segments, older patients, to have medical options for treating aneurysm disease, and it would be useful to have a better understanding of patients who have aneurysms, who's at greatest risk for death from aneurysm rupture, to better focus the effective surgical therapies that we now have. It's important to consider that almost all the research that we've just talked about this morning was done by vascular surgeons around the world. So this contribution of vascular surgeons to the understanding of aortic disease is really remarkable from both the surgical and the medical standpoint. This is one of the few areas of our practice where we are the experts in this problem, and from epidemiology to genetic risks to biomarkers to effective therapies to public policy about screening. You know, abdominal aortic aneurysm disease is the only cardiovascular screening test covered through Medicare. So it's important just to take a moment to recognize that this is really this lexicon of knowledge about aortic aneurysm disease is really a tribute to our colleagues and our predecessors in our specialty. There's evolving therapeutic options, and it's likely that in the very near future there'll be effective medical therapies that'll improve our ability to provide the optimal care for most patients. And you know, I got an email from a guy in the UK a few years ago that wanted to work in our lab, and he he told me, that his impression from reading literature was that we're on the cusp of solving the aneurysm problem. And I think that's true, actually. I think that we will see a resolution of this disease in our professional lifetimes. We'll come to understand exactly what causes it and how to best treat it for all patients. So this is our aneurysm research group at Stanford. This is Phil Zhao, who was head of our biomarker core for our SCOR, the microRNA papers with Lars Magdfessel, who now is at the Karolinska Institute, worked with Phil Zhao when he was at Stanford. John Myers is the exercise physiologist who did most of the exercise work for the AAA STOP study. Mike McConnell is a cardiologist interested in molecular imaging who's done most of the molecular imaging work related to our group. Some of you may know John Cook. He's a vascular medicine specialist, is well known in the United States. This is Neris, and these guys are our biostatisticians from the SCOR group. And we've really been fortunate at Stanford to have a large number of capable collaborators really help us drive this research forward. And lots of colleagues and prior trainees in my lab, including some of you know, John Karwowski, who was previously at Cornell, worked with me previously, and Naoki Fujimura and Baohu Shu are the guys working in my lab currently. So thank you very much for your attention. Dr. Marin.